So I have to teach you everything I know about PE in 20 minutes. So I'm not sure what we're going to do with the other 19 minutes, but we'll see what we can cover here. Nice to be south of the border here. I come from Wisconsin. I have no disclosures other than the fact that I'm from Wisconsin. So very briefly, a case study. A 35-year-old man with astrocytoma is getting chemotherapy. He has progressive fatigue, exercise intolerance. He has several days, the medics come to his house and he arrests right in front of them. They do CPR, immediate return of spontaneous circulation. In the ED, he comes in and looks shockingly good for a guy who just died. He's got relatively normal vitals. He's alert. We get a CT, and it looks like that. That is a saddle pulmonary embolism. There is a big honking clot sitting right across the main pulmonary artery. BNP and troponin are elevated. TTE and echo shows a dilated dyskinetic right ventricle consistent with pressure and volume overload. And then we get an ultrasound that shows not only that, but he's got a residual clot in his popliteal vein. So this is a man who has had a PE that was bad enough to kill him, who now looks pretty good, who has a residual clot sitting in his leg, and oh, by the way, he has a brain tumor. What do you do with this patient? And so I am the head of the director of the PE response team at St. Luke's, and I sort of feel like this guy when I'm confronted with a case like this, you know, damned if I do, damned if I don't. I don't know if there's a bullet in the chamber. So briefly, let's talk about PE so we're making sure that we're talking about the same thing. Remember that PE severity is a hemodynamic definition. So low risk is no RV dysfunction, high risk is hypotension or shock, and this intermediate or submassive group is RV dysfunction but hemodynamic stability. And that point number one that I want you to take home is that PE kills because of right ventricular failure. Some patients get very hypoxemic with PE. Those are typically patients with underlying lung disease or patients who pop open a right to left shunt as a result of the PE. But it's rarely a diagnosis of gas exchange. It's a diagnosis of a failing RV. You will get calls from the ED. They'll say, we see a massive PE. And what they mean is they see a big, scary looking PE on the CT. Remember, it's not about the size of the clot. It's about how the clot is affecting the right ventricle. The clot burden, the amount of clot that you see, does not tell you anything about the severity, the mortality, the one-year outcome, the likelihood that they're going to progress to have complications. So again, it's not the clot, it's how the RV responds to the clot. Ken Wood published this in 2002, a former colleague of mine at the University of Wisconsin, and he intuited some important things about severity and outcomes in PE. The first thing is you would think that mortality and severity and sort of the amount of clot that you have and how your RV responds would be linear. And the answer is it's not. It's more of this curve with an inflection point. And when you hit that inflection point, things can go from okay to not okay in a fairly big hurry. We know what to do with these patients who are at low risk. We anticoagulate them, they do fine, they go home. If the patient is dying in front of you, you know what to do with those patients as well, right? You need to somehow decrease the clot. You do some form of thrombolytic, whether it's mechanical or chemical. We really don't know what to do with the patients in this box, or at least for a long time we didn't, although that literature is becoming somewhat clearer. And we're going to spend the rest of our time talking about what do you do with the patients in the gray box. And if you notice, that gray box covers a big area, and you might even argue that the patients on this side of the gray box are really not the same as the patients on that side of the gray box. So, to cut to the chase, we're not going to go through all the articles. What do we know about patients in that gray box? What does thrombolysis do? So it turns out that it makes people less likely to decompensate. It makes them feel better faster. And if you use aggressive thrombolytic regimens, it makes them bleed, especially if they're elderly. What do we define as elderly? Over the age of 75, 65 to 75 is sort of the gray zone. What it does not do, it does not reduce in-hospital or long-term mortality. It does not reduce the likelihood that you're going to have a recurrent PE, and it does not reduce the likelihood that you're going to progress to chronic thromboembolic pulmonary hypertension or long-term complications of PE. Let me say that again. thrombolysis in submassive PE does not change long-term outcomes, does not reduce the risk that the patient is going to die. There is only one reason to thrombolyse a patient who has a PE, and that is to keep them from dying in front of you. That's it. That's the only reason. And there are two reasons that patients with submassive PE die. They either slowly deteriorate in front of you, they get a little more tachycardic, they get a little sicker, things start to deteriorate. Those are the ones that don't scare me so much because they warn me. The other reason that they die is that they have another clot sitting in their leg or somewhere else, and they get up and they walk, and bang, that clot pops off. The RV is already compromised, and they drop dead in front of you. Those are the ones that I think terrify most of us because you don't necessarily see those ones coming. As a result of all of this, PE has become something of a Rorschach test depending on your cognitive biases and your specialty. So if you're an intensivist, your response is just don't make them bleed, please. If you're a cardiologist, it's I can't abandon a sick RV. The RV looks terrible on the echo. I can't send that patient home. If you're an emergency physician, your response is it doesn't matter what I do, someone's going to blame me for the result. So the question is, in patients who have submassive PE, should we routinely thrombolyse them? And the answer is no, definitively no. Most patients with submassive PE do not benefit from thrombolysis, and some are harmed. But as I said before, this is a spectrum of illness, and can we identify the patients on the right, on the right end of that gray box? Sorry, I'm pointing left, to my left. Can we identify the highest risk subset of those patients and perhaps thrombolyse some of those patients? The European Society of Cardiology tried to take a crack at this. They said, okay, if we have patients who have an abnormal echo or a CT that shows RV strain and elevated biomarkers, BNP or troponin, those are high-risk patients in that category. And if they have only one of those two, then they're at some lower risk. Sure, that's a useful, I guess, construct. It's also completely made up. It's not based on any real data. I don't know about you guys, but up north of the border, we're using N-terminal proBNP as our BNP. And I think if I were to tap you on the chest a couple times with my fist, your BNP is going to be elevated. I really don't even know what to do with this test anymore. So I'm not sure how helpful this is. But I do think that we have, again, we talked about that patients with submassive PE either steadily decompensate or die because of a second hit. So who are the patients who are at risk for a second hit? The patients who have more clot. And the two groups of patients who have submassive PE who I get worried about are the patients who have a residual proximal DVT or a thrombus in transit. We do the echo and we see clot sitting in the heart, especially those patients, very high risk. So those are the patients who I am more likely to think about thrombolysing. There's another clot sitting there. I'm worried if it breaks off, that may cause the patient to tip. And there are some data, and the citations are below to support this. One key point about IVC filters, the indications for them are vanishing at a rapid rate. The only patient who should get an IVC filter is the patient you absolutely cannot anticoagulate or thrombolyse. If you have a patient who's had a big PE and has a clot sitting in their leg, the answer is don't put an IVC filter in. The answer is thrombolyse that patient. That should be the approach. If you cannot do that, then I think you should consider an IVC filter, but that should be really quite rare. So how should we do it? And the big issue now is, should we use catheter-directed thrombolysis or systemic thrombolysis? And catheter-directed thrombolysis has been held out as the holy grail for management of acute PE, right? It's safer, it's sexy, we have this new catheter that jiggles, so that's really cool. So perhaps we should do that, and this is becoming the standard of care at many institutions. So let's talk a little bit about catheter-directed thrombolysis and specifically the ECOS catheter, which is the only FDA-approved catheter. So the idea is that we're giving centrally delivered thrombolysis through a catheter that's parked right above the pulmonary artery. The idea is as a result of that, because it's sitting right on top of the pulmonary of the clot, we can give a much smaller amount of TPA, as little as perhaps even 6 milligrams of TPA. The ultrasound supposedly breaks up the clot more to allow more TPA to interdigitate into the clot. And the idea is if we can give a lot less TPA, it's safer than systemic thrombolysis, right? Not so fast. First of all, there are 3 studies that have looked at catheter-directed thrombolysis with the ECOS catheter. They are randomized against nothing. They have never been compared head-to-head with systemic thrombolysis. This catheter requires a certain degree of technical expertise. You cannot do this at every hospital. There's potential therapeutic delay. In the patient who has a submassive PE who is stable, there's probably no need to, that delay is probably justified. Then again, thrombolysis probably isn't justified because the patient is stable, okay? And then the final thing is that these catheters have some really perverse incentives associated with them. They're hellaciously expensive. Depending on your acquisition costs, are between 10 to 30 times more expensive than a standard pigtail catheter, with no evidence to show that they're superior. In fact, now evidence to show that they're non-inferior at best. And then the perverse incentives. So in a busy day in the ICU, if I generate 25 RVUs of activity, I'm doing pretty damn well. You can generate 26 RVUs by putting in 2 of these catheters in about 30 minutes. There is an enormous profit margin on these, both for hospitals and physicians. And one of my concerns about this becoming standard of care is when you're generating a lot of money doing this, perhaps everybody gets a little more excited about it than they should. We haven't drank the Kool-Aid north of the border here. We are not doing this. And I think at this point, it is not clear that this should be the standard of care anywhere. And I'm being a little bit intentionally provocative here because I know this is done down here, and I was asked to kind of be in. So here we are. It comes naturally. I think the other question that we need to ask is, okay, we know that systemic thrombolysis makes people bleed. The Pytho trial demonstrated that. So is there a way that we can do this more safely? And I think the answer is, yeah, we probably can. And I'm going to ask you to think about 3 different things when we thrombolyse people: revising our goals, revising the dose and duration, and talking about anticoagulation. So let's talk about revising our goals. It used to be that we thought we have to give enough TPE to make that RV look normal. No, we do not. We need to give just enough TPA to keep the patient from dying. We know that 97% of patients who come in with RV dysfunction will normalize their RV over the long term, whether we anticoagulate them or thrombolyse them. It does not matter. So all you need to do is give them enough thrombolytic to keep them from dying, to pull them back from the edge of the cliff, which means we can probably give a hell of a lot less than we've been giving in the past. This notion that if you park the catheter sitting on top of the PA, that you can give less thrombolytic is very sexy. We have no idea what would happen if we gave less thrombolytic through the arm, right? We know that even when you give thrombolytic here at small dose, there is a systemic effect. There is no evidence at this point to show that there is anything magic about giving the TPA here versus giving the TPA here. So the first issue is revising our goals. This leads into this issue of dosing of TPA and the duration of the dose. And my point here is that when you think about how we give TPA for DVT, right? Someone comes in with a big DVT, you're worried about a post-phlebitic leg. How do we give TPA? They park a catheter right in the leg, and they dribble in TPA at 0.5 milligram to 1 milligram an hour and let that TPA slowly dissolve the clot. And yet when you come in with a submassive PE, we give you 50 to 100 milligrams of TPA over 2 hours with absolutely no monitoring while you're anticoagulated, and then we wonder why you bled, okay? If you come in with a massive PE and you're dying in front of me, the answer is I should give you a bunch of TPA very quickly. How much? Probably not 100 milligrams over 2 hours. I should give you all of it right now. And so our protocol is actually if you're in shock with a PE, you get 50 milligrams of TPA bolus dose. You're going to die. You don't have 2 hours. The flip side is if you have a submassive PE, you are by definition stable. We can give you a little bit of TPA dribbled in over a longer period of time with probably a much safer, much lower risk of bleeding. Again, I don't have to make your RV normal. I just have to pull you back from the edge. So anecdotally, I can tell you that this works. We have done it. We have had patients, for whatever reason, we did not think we could systemically thrombolyse them. We did not think they were a candidate for catheter-directed thrombolysis. We have given them low doses of TPA, either peripherally or through a central line that they had. One had a Metaport with excellent thrombolytic effect and no bleeding. That's anecdote. That's not randomized. We don't know, but my suspicion is that it works. And finally, this issue of anticoagulation. Why are we thrombolysing people who are fully anticoagulated? How does that make sense? We do not do this in any other thrombolytic regimen that we do. If you have an arterial clot, if you have a DVT, we do not anticoagulate you and then give you a thrombolytic. We may run a low dose of heparin, closely monitoring PTTs, but somehow when you have a PE, it's magic, and we have to do this while you're fully anticoagulated. And I think the answer to that is nonsense. And in fact, our protocol is now, if you have a submassive PE, if you've come in and you're anticoagulated, maybe they heparinized you in the ED, we let your PTT drop below 40, and then we give you the TPA. And we give it to you peripherally. And we think that that is going to significantly lower the dose. Incidentally, how did we come up with 100 milligrams of TPA as the dose? That's from the MI and stroke literature. Well, it kind of makes sense, right? If you have a tiny clot in your left anterior descending artery, if I have to give you TPA through your arm, I got to give you a hell of a lot of TPA to make sure that some of that gets to that tiny little artery. In contrast, if I'm giving you TPA that's got to go through your pulmonary arteries, all the TPA goes to the pulmonary arteries because it all comes back to the right ventricle. So there's reason to believe that a lower dose of systemic TPA might be entirely efficacious with considerably less risk. There's actually a randomized controlled trial that's enrolling in New York right now that is looking at exactly this issue. Catheter TPA delivered through pulmonary artery catheters versus the same dose of TPA dribbled in through a peripheral IV. And I think that what we're going to find is that we can safely manage submassive PE with peripheral low-dose TPA, that there's nothing magic about putting a pulmonary artery catheter in most of these patients. There may be a subset of patients in whom it is, and if you have a patient who has an extraordinarily high bleed risk and you do feel that you need to treat this PE, the Optilice trial suggests it can go as low as 6 milligrams of TPA. There may be a very small subset of patients in PE for whom a pulmonary artery catheter may be the way to do this. But my suspicion is that in 5 years, we're going to look back and say this was not nor never should have been the standard of care. So how do I think this is going to evolve? This is, if you read one article about submassive PE, Josh Farkas wrote a really, really well put together thought piece on this in PulmCrit. And if you sort of look at the evolution of this, right, we started with heparin, then we gave full dose lytics, then we gave the half dose lytics, then this idea that we would do catheter-directed thrombolysis, and I suspect that we're going to do more and more of this with our patients with PE as time goes on. We're going to get away from taking people to the cath lab for their PEs. Again, I want to be clear, I'm talking explicitly about intermediate risk or submassive PE. If the patient is in shock, if this is a massive PE, none of this applies. You need to get that clot broken up. You need to get it broken up fast. That is either a big bolus of systemic thrombolysis, probably 50 milligrams pushed quickly, or mechanical thrombolysis in the setting of someone who cannot be safely thrombolyzed. Believe it or not, I actually ran a little under time, which I don't think I've ever done before. So give someone else a little time. Thanks for your attention.